This is Kirsta Glenn with the Healthcare Authority AIM team, and we are set up today as a WebEx in order to kind of facilitate a technical assistance session that David Mancuso is going to be presenting. But we might also be kind of testing this out for future calls as well, because it would be a way for us to share templates and data products and walk through those products together. So although today we're not going to, I think we're not going to have actual Excel spreadsheets up, it's more of a test to see how this works for us. So the limitations are that only the presenters can speak, and so the rest of you will need to use the question pane on your screen. So it says, sort of the directions are, please use questions section in the webinar panel to submit any questions or concerns you may have. Our panelists will answer questions at the end of the presentation. So as you ask those questions, Missy, who's here to assist us, will forward those on, and I'll probably read them out because David is remote, and then he can answer them if they're requested of him. David has available until 3 p.m., so I want to get right into his presentation, and the session or the call has been extended to 90 minutes, so we can take the last 30 minutes to kind of give you an update from the AIM team here at the Healthcare Authority. So with that, I'll hand things over to David, and as I said, by all means, please share your questions as they come along. And I'm not going to do a roll call today because we do have a record of everyone who's on the call. So if ACHs also want to know who's on the call, please let us know, and we can distribute that information so that you know which of your fellow ACHs are also attending the call. So David?
All right, thanks for that introduction. Yeah, I guess I would echo the encouragement for folks to type in their questions as we go along. So what I'm going to be doing, I do have a list of roughly a dozen questions that have been accumulated related to behavioral health data topics. And I'm basically going to go through the list that I have to give answers to at least how we in RDA would approach addressing a particular question. And I'm quite sure that we've got some additional content that would be shared electronically probably after this call is done, that would include some documents that would provide a permanent record of some of the information I'm sharing here, so you don't necessarily have to rely on reviewing the recording or your notes. So again, I'm going to go through about a dozen questions that have been provided to me. A few of them connect to Excel, PowerPoint, Word document content that I think we can make sure that folks have and can get and reflect on. And look forward to getting any questions that you might have along the way, either during the hour today or afterwards. Okay, so the first question that I have is, how are the following types of conditions identified in Medicaid claims data? And there's a parenthetical note to keep it at a high level, which is great because then I don't have to give you an exhaustive list of ICD-9 or ICD-10 codes. So the conditions where there's interest in getting more perspective on how we define them are, so they're given to me as mental health. I'm interpreting that as mental health need or an indication of mental illness. SMI, or an indication of serious mental illness. Behavioral health is the third one that's given to me here. One that's not here but probably intended to be here was substance use disorder. And so in that list of four sort of risk or diagnosis concepts, mental health, a somewhat broader concept, SMI, serious mental illness, a narrower subset of overall mental health need or mental illness, substance use disorder treatment need, or substance use disorder diagnosis, all of which comprise behavioral health. These are definitely the major groupings that we tend to work with. So let me go from the top down. So we use the term behavioral health to refer to both mental illness and substance use disorder. So if we say somebody has a behavioral health need, we're referring to them having an indication of mental illness and or an indication of substance use disorder. So it's a broad catch-all capturing both the mental illness component and substance use disorder component. So I think we can move on from behavioral health. I think the key thing from a language perspective, sometimes I hear people using that refer to only mental health or only SUD, and we certainly don't use the term that way. It's meant to comprise both as we understand it. Okay, so let's move on from that to mental health. And it's the way it came to me. I would frame that as mental health service need, which we use pretty synonymously with the concept of an indication of mental illness. One of the things I think we can share after the call would be a very precise set of specifications that comprise our definition of mental health service need. It is built, as we use that concept here, built off of diagnosis, pharmacy, and service information. And there will be, for example, 7 major mental health diagnosis groups that we use in our main data warehouse that would comprise an indication of mental illness. Just to give you a high-level sense of what those 7 diagnosis groups would include, there would be one that included schizophrenia and related psychotic disorders. There'd be another that referred to mania and bipolar disorders. There'd be another one that was related to depression, another one to anxiety, another one to adjustment and related disorders. ADHD would be another, and another one that would pick up on sort of impulse control and things that align more with childhood psychiatric risk factors. So those diagnosis groups, we're going to follow up from this call with the specifications so that you can get those groups in their gory detail. That would be one aspect of how we identify mental health service needs. A pharmacy component that aligns from a drug therapy class perspective to most of those diagnosis groups. So there's an antipsychotic therapy class, an anti-mania therapy class, an antidepressant therapy class, an anti-anxiety therapy class, and an ADHD medication therapy class. We most commonly use receipt of medications in those classes as an indication of a mental health service need, with caveats that there is off-label prescribing. There can be the use of, let's say, antipsychotic medications in populations with developmental disabilities, for example, that we might be picking up in that context. But nonetheless, our main mental health service need definition includes the psychotropic medication component of the definition. The third big component of our mental health service need definition would be the things that we actually think of as mental health related services. Individual group therapy, psychotropic medication management, peer support, crisis encounters, psychiatric inpatient services. Almost all of those events are going to meet the diagnosis criteria, so it's in a way kind of duplicative to call them out separately based on the kind of the procedure or the nature of the service modality, but nonetheless that is part of the definition, and you'll see that when we share the specification. Okay, so that's about broader mental health service need. We do, in a number of contexts, use a proxy for serious mental illness. And for that, we tend to rely on a subset of the diagnosis groups and a subset of the psychotropic medication categories where we're actually, our current practice is most commonly to rely on the chronic illness and disability payment systems, psychiatric high, psychiatric medium, and psychiatric medium low risk categories, plus the antipsychotic anti-mania risk group in the Medicaid RX system. The reason that we do that is that the CDPS tool gives us, in a kind of a nationally stewarded tool, if you will, some distinctions that our depression, internally maintained depression diagnosis group doesn't do between major recurrent depression and other varieties of depression. So in in words, our SMI definition would roughly but fairly accurately align with schizophrenia and related psychotic disorders, mania and bipolar disorders, major recurrent depression, or receipt of antipsychotic or anti-mania medication. So those would be the things that we would use to pull out of a larger group identified with a mental health service need, including those who might be diagnosed with ADHD or anxiety. We would pull out those with indications of more severe depression, as well as schizophrenia and related disorders, and mania and bipolar conditions. So that is the SMI piece. So the one piece then remaining is the SUD piece. And for that, so our substance use disorder treatment need concept does have a kind of a similar set of group of things that we're looking at there. There's a diagnosis component, there's a pharmacy component, which is largely buprenorphine prescribing, and there's a service component. And these would all parallel the mental health service need side, except that on the SUD side, the diagnoses align to alcohol or other substance use disorder diagnoses. In the old world, abuse or dependence. In the new world, alcohol or drug use disorder diagnoses. That's the diagnosis side. And again, we'll follow up with the detailed specs, so we'll have it down to the exact code sets that are part of our definition. So we do have a few classes of medications to treat substance use disorders. Buprenorphine most commonly, but also disulfiram, a few other active ingredients. And we think of those as treatment as well, but they are part of what goes into the need definition. And then on the service side, we have anything that we would consider to be substance use disorder treatment is considered to be, almost by definition, perhaps literally by definition, an indication of a need for the treatment that was received. So that would include outpatient or residential substance use disorder treatment as commonly understood through procedure codes or related codes in claim and encounter data. It would include methadone treatment, would include medication-assisted treatment of all types, not just methadone. And it would include case management as well, thinking of things that have been part of the DBHR stewarded substance use disorder system. We include now co-occurring disorder services that are coming to us through DBHR's Behavioral Health Data Store. And let me say the one main piece that is included in the definition of SUD need that is not considered treatment would be the experience of detox. So if we see somebody's been detoxed, that's treated as indication of need, but not as an indication of treatment, which we'll talk a little bit more about when we get to the third question on the list, which is service penetration, the service penetration concept. Okay, so I'm going to pause there. So that really addresses question number one about how we identify different types of conditions in Medicaid claims data. The second question is kind of a follow-up to that. Are claims and encounters included? And the answer is yes. And if we're measuring information for, let me actually answer that a little bit more completely. On the Medicaid side, then what we're pulling together would be MCO. What HCA MCO contractors are providing, including their FIMC, fully integrated managed care contractors in Southwest and soon to be North Central. If we're looking over a historical period that precedes April 2016, we're scanning the RSN encounters as well as outpatient encounters that might have been funded through the county administered substance use disorder outpatient treatment system. Residential encounters for substance use disorder services that we would have, would either get now through BHOs or in the past have gotten through DBHR. So all of those encounters would be included in our scanning for these conditions to identify the presence of mental illness or substance use disorder or both. Where we have somebody that's dually enrolled in Medicare, we do integrate Medicare Part A, B, and D data for the folks who are not in managed Medicare. So that's the Part C population. And we do also integrate assessment data from the CARE assessment tool that is maintained by ALTSA and has information for people who are in the home and community-based long-term care delivery system. So that system contains ICD-9 and ICD-10 diagnosis codes, and we sweep those into our identification process. In many cases, what CARE contains will duplicate information that we're also getting through Medicare for people who are duly eligible in particular, or information for Medicaid only that we're already seeing on the Medicaid side. But it's at least a supplemental perspective. Okay, third question. And let me say one more thing. So about our claims and encounters included, there are some reporting applications where on the SUD need side, we are including arrest information from the Washington State Patrol arrest database that we use, where we have charge descriptions that are identifying things like driving while intoxicated or possession of an illicit substance. So for some applications, we include that information. For most of our kind of healthcare-facing reporting at this point, we're not using the State Patrol arrest information, in part because the main motivation there is that our assumption we're operating in an environment where others are who may be interested in comparisons are only going to have access to health service data for their enrolled populations, and they're not going to have a State Patrol interface. Numerically, the State Patrol data adds a pretty small additional volume of identified need in Medicaid populations, so it's not a huge proportion, even where we are using it. Okay, going on to the next question, which is, how is service penetration for SUD and mental health calculated? And we have detailed measure specs for that in a website where we maintain those. We'll make sure we share that electronically with folks. I do want to let folks know that those specs are undergoing some revisions and expansions, essentially, and expect that probably no later than the end of this calendar year, we will have updated versions of those specs on our website. And the specs are being modified basically to be better prepared to handle the way that fully integrated managed care plans are reporting their behavioral health services, and also making some improvements to how we're picking up, in particular, the management of mental health conditions that are happening in a primary care-like setting. That has been a component, that concept has been a component of our broader measure of mental health service penetration, and we're expanding it further to pick up services that are delivered in-home or in a community residential or nursing facility setting, as well as better coverage of telephonic encounters. So I would just encourage folks to know that when they do get our current specifications, that those specs are in the process of revision and should be available within the next couple of months in their revised form. And when we do make them available in the revised form, it should include all of the detailed underlying code values that one could use to implement a comparable spec in a different environment, with caveats about the range of data that might be available to apply the specification over. And I guess, so I'll probably leave more of the detail about that to let folks get those major specification documents, as opposed to my repeating. They're pretty short documents. I think they're relatively clear, and I'd be happy if there were follow-up questions that people had about those specifications. We could either perhaps do that by email or have some time in a similar venue in future. But since we do have those written up, I think we can get those specs out for people to review and help us understand whether people still have questions about how those metrics work. So the next question is, what are other relevant behavioral health measures? And let me call out a few that we know are going to be part of some of our ongoing work in a variety of areas, or these are ones that we use we think of as part of our behavioral health related measure toolkit that we might deploy for any particular evaluation or performance measurement process where they seem like a good fit. So the earlier question was about our penetration rate measures, which are really designed as a sort of a minimum threshold access measure. So that you could think of them, if you're putting them under a rubric of kind of what concept they're getting at. The SUD and mental health penetration rates are measures of access. Does somebody have at least one, I'll use the term approximately therapeutic encounter over the course of the year, and where that measurement is restricted to those who show some indication of needing a therapeutic encounter in that time period. The other measures that we're using in a variety of settings include a family of HEDIS measures. Some new HEDIS measures for 2017 include a measure of follow-up after an ED visit associated with the diagnosis of alcohol or drug use disorder, FUA, if you're a fan of NCQA's 3-character acronyms for their HEDIS measures. There's a parallel FUM measure for a measure of follow-up after an ED visit for a mental health condition. And these are measures, they're kind of like FUH, follow-up after psychiatric hospitalization, in that they have 7 and 30-day follow-up windows. And these are measures that we are bringing into contexts like the fully integrated managed care monitoring and evaluation work that we're on point for. And I think, although I always have to remind myself, they might be in the toolkit area for ACH projects. If I'm wrong, forgive me for making that connection. So these are well-defined HEDIS measures. There's NCQA has copyrighted documentation. I think of these as good proxies for coordination because they both involve what happens after somebody is seen in a setting that that people visit most commonly for physical health care issues, and it's an event that's identifying a mental health need, and they're measures of how timely somebody's access to follow-up services for mental health or substance use disorders, the case may be. How timely is that? So it's a couple of measures that we tend to put under a kind of a coordination rubric if we're organizing our measures in that way. Another measure that we're working with is the psychiatric 30-day readmission rate. It's a homegrown variant of the HEDIS PCR or all-cause readmission rate, where what we're looking at is focused on discharges from a psychiatric inpatient setting, and the readmissions that we're measuring are, if they occur within 30 days, are those in psychiatric settings. We also have homegrown specs for that measure, so we should share that as well. We do have HEDIS psychotropic medication adherence-related measures. There's an antipsychotic measure, SAA. There's an antidepressant medication management measure, the AMM measure. Those are ones that we're also working with, and we see some utility in having them be part of our available measure set. And there are a few other HEDIS measures, one looking at some that get at the cardiometabolic risk associated with receipt of antipsychotic medication. So we do look at HEDIS and the evolving set of things available through HEDIS as potential candidates to be brought into our environment. So these are at least some of the ones that we're tracking and routinely producing for general analytical purposes. So I'm going to move on to that. So next question is, how How is measuring behavioral health different under BHOs than RSNs? And then the next one, so maybe I'll take these take these together. How is measuring behavioral health different in the FIMC region versus BHOs? Have definitions of things like SMI changed? So let me say a fair amount about this set of related topics. So one thing that we don't do as we're working with data that spans the pre-April 1, 2016 RSN era, the pre-April 1, 2016 era and the post-April 1, 2016 era, we're generally not trying to replicate what access to care type criteria would look like in the new world if it were still operating in the way that it did in the old world. And instead, we're working to develop common definitions that look like they work pretty seamlessly over time, meaning they do things like produce credible and stable time trends before and after April 1, 2016. And there are other challenges in having the measures that we work with be stable over time. For example, like the implementation of ICD-10 really having a significant impact on the diagnosis-based identification of opiate use disorder. That coding change was implemented October 1, 2015, and we see a much higher monthly number of folks identified with opiate use disorder, a real level change that doesn't reflect growing caseloads or growing need that might be part of a larger, longer background trend, but really a discrete jump, a rough doubling that reflects ICD-10 impact, presumably on coding. So there are larger, there's that issue as well in maintaining consistent time series. So connecting back to the questions that were on the table, so we're not really trying to maintain kind of a stable, this is what SMI would look like if a BHO were operating in Southwest. We do have a SMI proxy that we use, and we apply it over all time that we're interested in measuring. It's, as I mentioned earlier, it's based on diagnosis groups and the antipsychotic, anti-mania therapy classes. And that works relatively well to identify fairly consistent, stable population growing over time in ways that we would expect with underlying growth in the Medicaid caseload. Where we do have certainly major changes in how we need to organize data is in the service classification. So it's so the BHO FIMC implementation has big impacts on us in service classification. And driving that distinction, it has really not much of an impact other than data completeness issues on diagnosis classification like SMI. So we do have a set of crosswalks we can share that have underlying service classification approaches that we're applying to information from HCA contractors, MCOs, including FIMCs in the Southwest region. So we can share those specs so that you can see how we're using procedure codes and other information to map to modality concepts like outpatient mental health treatment and methadone treatment and so on. And we do have comparable modalities that we build around on the legacy RSN and BHO and the SUD, legacy SUD side as well. So, so I think probably the best way for us to proceed is to make those documentation workbooks available so that folks can understand how we're doing the classification. All right, I'm going to go on mute just for a moment to clear my throat and drink a bit of water.
Hi, this is Kirsten. I'll just, while David's taking a chance to clear his throat, I'll just say we've been getting a few questions, and
go for it.
Okay, great. One is, will the answers to these questions be provided in writing, not just the additional documents David is referring? An FAQ type document would be extremely helpful given the pace and lack of visual support for this information. And we weren't going to provide an FAQ. I think Missy has sent back an answer. This discussion is being recorded, and I think that the documents David is going to send are at least going to give a lot of detail around what's included in the measures and what's not, as far as the diagnosis and services. But I will.
Yeah, I just jump. Sorry, Kirsta. So far, with every question that we've covered, the documentation that would be provided would provide an exact answer with detailed specs. So I think the documents will address the specific questions that are on the sheet in front of me.
Excellent, and we'll definitely here at HCA we'll review the webinar, and if there is additional information that's helpful, we'll try to document that as well. And the second question is, will RDA provide historical data or proxy data with an update to the specifications? So David, you talked that the specifications were being updated, and I think our general plan, which is to provide an update of the historical proxy data that we've already released when calendar year 2016 is available. I think on the RDA side, they'll try to have exclusions be as similar as possible to those on the HCA side, which is to exclude duals at least, and to update with specifications. But knowing full well that there's probably going to be additional changes so that when the official baseline data is released in the late summer, early fall of 2018, there'll be changes between now and then. So an update with all available information, but that's still not going to be the specifications that may eventually be used in the late summer, early fall of 2018. So David, is that consistent with your understanding as well?
Yes. When we create a new measure spec, so a measure spec is basically an algorithm to be applied to a data repository. And when we create a enhanced next generation of mental health service penetration broad, for example, what we mean is we have a new algorithm that can be applied over all of the relevant claims history that would be of interest for the particular purpose. So it's not the case that we generated data the old way for 2013 and 14 and 15 and 16. Oh, we're changing to this new spec, so we can only look at data from 2017 forward. No, what we have is a new algorithm, and once we start using it, pretty much all of our products are at least producing 3 years of data, and there'll be a consistent time series with the new variation, the new version 2.0, version 3.0 of a measurement concept. By the way, that's just what we do with the HEDIS measures as well. Many HEDIS measures change from year to year in ways that are not just about underlying value sets changing because a new drug came on the market and so an NDC code set needs to be expanded. Sometimes there are fairly fundamental changes being made even to a metric that is known under a familiar acronym and has been in use for years. And when we code our algorithm to the new spec, it can be deployed across history so that we have multiple years. So yes, when we produce a new version of a measurement algorithm, we are generally in a position to report over history so that a baseline could be created for the new version of the measure. And Kirsta's also right that it's possible that some of these specs, because of new code sets, new information that's learned about how FIMC is being implemented in North Central, and that might lead to tweaks to our mental health broad measure to ensure that we're accurately reflecting that on a statewide basis, as well as in North Central. I mean, these are living definitions, and they may well undergo an additional round of revision beyond the one that I've already signaled will lead to updated documentation within the next couple months. So Kirsta, were there other questions that had come in so far?
I'll let you, there's a couple, but we can probably address them after your portion of the presentation. So I want to make sure you have as much time as possible to move through your material.
Okay, great. So the next question is, how about behavioral health services provided by primary care physicians? And you will see in the major specs that you get that there is a component of the mental health service concept that is designed to pick up management of mental health conditions in a primary care setting. That component is one that I mentioned earlier. It's being further expanded from the documentation you will get immediately, and in the next iteration of the document, it will call out not only things that might be happening in a physician office setting, but the delivery of similar kinds of services in home or in a residential facility or potentially in a nursing facility type setting. So yes, there are components here where we're working to pick up services that are outside of what regional support networks back in the day would deliver, outside of what BHOs currently would be delivering, and in BHO regions would reflect what MCOs, your partner MCOs are delivering in regions where you're operating if you're a BHO person. And again, the specs that we're providing will call out this in its gory detail. Next question, is medication-assisted treatment included? Yes, medication-assisted treatment for substance use disorder is included, part of the need definition. It's also included in the numerator treatment penetration concept. So if you're getting buprenorphine or naltrexone or camprosate or disulfiram, it might be another class, but it's almost all buprenorphine or methadone treatment. So buprenorphine and methadone are by far the dominant types of medication-assisted treatment for substance use disorder. Those would be included both as an indication of need, but also as receipt of treatment in the penetration rate concept. So next question. And let me just say that, again, the specs will call out, there'll be a medication-assisted treatment component to the specification, and we maintain value sets that would include the national drug codes that one could grab and make use of if you have access to a pharmacy claim repository to identify receipt of these different types of medications, except for methadone, which we identify through a HCPC code. Okay, how are behavioral services for duals identified and measured? So I mentioned that we do have access for duals to Medicare A, B, and D data. So Part D is pharmacy. What we do is we apply comparable value sets to what we apply to Healthcare Authority, MCO, and FIMC claims encounters. We apply those to our Medicare claims, Part A and B claims, and Part D encounter data. So that would include if Medicare were paying for buprenorphine, for example, we're scanning Medicare Part D data to see whether, to see those events. If Medicare is paying for a mental health treatment encounter, we're scanning a similar set of, say it's an outpatient encounter, we're scanning a similar set of criteria, procedure code, or related criteria to look for those events in Medicare data. So it's really, it all comes back to those underlying value sets and their application on different kinds of claim and encounter repositories. Next question, have there been challenges with measuring BH services with BHOs or MCOs? Yes, the main issue for us at this point is, and I haven't checked this week, but at least as of last week, we do have some areas for BHOs on the SUD side in particular where encounter reporting is not at the expected volume. And these are the areas that primarily, as I understand it, had formerly been in the realm of state direct contracting, so inpatient, residential, detox. Those areas of service utilization are below what we expect is actually being delivered, and creates a discontinuity as we look across time in the measurement of use of those services in the BHO regions. We do not see issues like that on the mental health service side more generally. And on the outpatient and methadone SED side, we see utilization that's at or above levels that existed prior to April 1, 2016 on the whole. So if there were any BHO folks listening who could be further motivated, as I'm sure folks are already motivated to try to get that encounter data to be more complete for detox and residential inpatient treatment, I think some assessment data as well, that would be immensely helpful. We do have a similar but different issue right now in the Southwest Washington region, where there have been rejected encounter submissions from a particular plan and a particular large provider that are leading to undercounts of both mental health and SUD service data in Southwest. So there is an issue we're still working through there as well. We have a little bit more direct control over fixing that because we can do change some things on our analytical side to work with rejected encounters that we actually do see in Provider 1. But yes, there have been issues of this type that do have some impact on some of the things that we can do. And where we have been reporting some information, we've been trying to be really thoughtful in not reporting information that we think reflects comparisons that would be more fraught with differences in level of completeness across regions. Okay, so next question is, what kind of behavioral tracking does RDA do? Are there established reports that can be useful to ACHs? We do reporting under the 1519-5732 rubric. Some of the updating of that has been, on the website, has been paused a bit while, from my perspective, we're kind of working on having one work group in particular sign off on those reports, including some additional data that we've not yet publicly reported. And there is more under the hood that we could probably share, but there are also a number of products that have been shared through HCA. At this point, I think sharing through HCA and having Kirsta and her team be the conduit, it works great for us because it pushes us towards greater alignment of the populations for whom we're providing information, especially as it connects to ACH planning purposes. So at this point, I wouldn't necessarily call out other RDA products that aren't coming through the healthcare authority connection. Yeah, so I guess at this point, I wouldn't necessarily point to focusing on the 1519 reporting as opposed to things that are coming through the HCA portal. Okay, the last question that I have on my list is, has RDA attempted to measure the impact of the transition to BHOs or to FIMCs? And the short answer there is yes, we are working with HCA and working with the University of Washington as, in some ways, the lead evaluation contractor in evaluating the fully integrated managed care experience in Southwest Washington. We do not have a project that involves a separate analysis of variation in outcomes by BHO. And our FIMC evaluation project really involves contrasting the experience in Southwest Washington with the experience in the balance of the state, which would be a blend of the experience in the region served by BHOs. There is a PowerPoint and supporting Excel workbook that I think folks will have the ability to access, will be distributed to folks after this call, which has a few slides describing the kind of the evaluation framework, and then several slides visualizing some of the first 9-month results in Southwest relative to the statewide experience. the Excel workbook has the region by region detail behind what we're summarizing in that PowerPoint. So I would encourage folks who are interested in that to have a look at that. And I can imagine there might be interest in having another follow-up to talk about that. And I believe I will be on a BHO meeting agenda probably about 4 weeks out. I think it's October 26th. That would be a venue where I'll likely be presenting some information, but I would expect that there might be interest in another venue in addition to that to speak to more than just the BHO audience about the approach to evaluation and what the first 9 months of experience through the end of calendar 2016 is looking like. So that's the end of the questions that I have. I guess with that one, so that's another area where folks are going to be getting documents that describe what I've at a very high level described will be coming. So Kirsten, I guess I'll pause to see if there are any other questions that have come in, or just another. I'll turn it back to you.
Okay, thanks, David. The other two questions are really not analytic questions, but more HCA policy questions. So let me just, since we're nearing the end of your time, let me just open it up a last time to the ACHs and see if they have any more questions for you. And if not, I can go ahead and answer these more policy-oriented questions. So I'll just give the ACHs a couple of minutes here to compose any questions. And as David has mentioned several times, he's available for additional follow-up questions, especially I think once maybe you get the specification documents, additional questions might arise. All right, well, it doesn't look like anything's coming in immediately. So thanks so much, David, for presenting all that really valuable information. And good luck with your further meetings this afternoon. And I will go ahead and answer the few follow-up questions that are more policy-oriented.
Thank you.
Okay, so one question was, how is HCA RDA planning to address ongoing changes in specifications over time once ACHs enter pay for performance and need to have stable pre-post measurement periods for comparison? And that's a really great question, and one that I think other district states have faced before us, and we are following their lead. So we're just implementing these projects over a dynamic period of time, and the specifications will change. And there could also be, I think we all realize at the federal level, some significant changes in legislation about Medicaid eligibility, and that might have an impact as well. So the easy answer is it's really going to be case by case. If there is a significant change, the specifications will be reviewed every fall. Adjustments will be made. If the change is not significant, a lot of times these HEDA specification changes are very small. There's likely not to be an adjustment. So that is the answer I've gotten so far. And again, that's more of a policy question. I think where we on the analytics side can help out is trying to inform decision makers with the likely impact and magnitude of a change, especially where there might be small samples. A change might have more of an impact. So that was one question. And another question was, is there an official final decision about whether duals will be included in ACH performance measures? I know there was some confusion about this decision on the last call. So no confusion anymore. The dual eligibles will not be included in the calculation for performance measures. So we kind of made that decision across the board that they're going to be excluded for consistency's sake and for simplicity's sake. So as I mentioned earlier, when David and RDA updates RDA curated measures that have previously been released with duals, they'll be excluding dual eligibles. I think David provided some context around duals because the dual eligibles are still an important part of the Medicaid population and tend to be a vulnerable and maybe expensive overall population, but just because of data limitations, we are excluding them from measure calculations. So those were the 2 questions I got. And please provide us feedback if this type of TA session was useful, and if we do further technical assistance sessions in the future, how could we better support you to make them a useful and valuable resource. This one is being recorded, and so you'll be able to go into and listen to it again if you want. And David is going to be sending the supplementary documentation that he referenced. So with that, we are just about at the top of the hour here, and I hope that most of you will be able to stay with us until 3:30. There was a request on a previous call to provide more time so that we could undertake some technical assistance and maybe have some deeper and more in-depth conversations and discussions. And so to accommodate that, we're thinking of extending the data calls regularly to 90 minutes, but then if we only use 60 minutes, we can just end early. So that's a plan. And also with that is to keep this WebEx format. It doesn't facilitate a conversation. It more facilitates a presentation. So if we find that that's limiting for us, we can always go back just to the general data call. But we'll try on the next call to more fully utilize the ability to walk through data products together. And that will maybe give us all some more information about how useful it is to have the WebEx functionality. And I'm just going to give a few general updates, and I'm going to start turn this over to my staff to give updates on data products they're working on. But on September 18th, Monday, September 18th, we had a call with the executive directors, and I think most of the data leads, so thank you all who were able to be part of that conversation, on the Development Council call. And Manat, on that call, gave an update of some data assets they're creating and I think are going to distribute, and also talked a little bit about the engagement that they're involved with the Healthcare Authority through this fall. So the Healthcare Authority did make an investment to continue to engage Manat this fall to really provide technical assistance to the healthcare authorities so that we can better serve the ACHs over the course of the demonstration. And that work is in 4 main areas. One area is strategic planning. So over how the data needs for accountable communities health are likely to evolve over the course of the demonstration and what we need to start preparing for now. They also did a data gap assessment. They're looking at data sharing and levels of data sharing that could be useful, and then health IT investment. One of the questions of the executive directors was to be engaged in that work and to receive more information. So we haven't had a follow-up meeting with Manat yet, but we'll certainly work with them to respond to that request. The Healthcare Authority is moving towards distributing analytic-ready data, and we're really excited about this and think that you're gonna find that these are very useful data products to have. They are de-identified, so they don't contain person-identifiable health information, but they're not suppressed at the level of the publicly available data products and will allow more analysis either through machine-readable format or through Excel. But we're working through sort of a more extensive review process within the healthcare authority, because the healthcare authority hasn't distributed this type of data product. We think this time is well worth it, and once we've ironed out our process, we're hoping that we can start to distribute these much more quickly and seamlessly to you. And Karen, at the end here, will give you a bit of an update on sort of final parts of that process. So I have most of my analysts collected here, so we'll go around and they can give you an update on the data products they're working on. So Shubha?
I am working on the behavioral health and co-occurring data product for ACHs, and we are aiming for end of this week, Friday, release for all of ACHs. Pierce has already gotten this, so hopefully that, hope to have that to you guys this Friday. And also, Shalini had to go to a meeting, so I'm going to update you guys on the MAT data product, the medication-assisted treatment program data product, and she wanted to let you guys know that it's currently being looked over and validated with other provider data sources, and to expect that next week. So we're just she's doing some final matching and validating with other providers to make sure that we've got the right things for you guys.
And Stephen's not here, so do you want to give an update on the PRISM data product?
Yes, so the PRISM data set, we finally got validation and sign off on our data set. So the next step is now to now fill in the shell tables that we had shared with you guys previously in the previous weeks. So we're hoping that by at least mid-October to have that data product to you guys. It took us a while to get that data set validated with all of our partners. So that should also be coming sometime in October.
Great. Dana?
Well, I have worked on our first sensitive category 2 data product for Greater Columbia region. I think it's about to go out now. It was basically our test pilot case. So we used it to establish processes to create the report and to go through a number of reviews, since it is a sensitive data product and we need to be sure that all the dots are checked. And now that it is going out, I will be working on the similar reports for other regions if there is interest for those reports by other regions.
Okay. John?
We're now starting work on the version 2 of the provider volume reports. Now that we can share with you unsuppressed data, we can provide finer detail on certain categories. For example, we will provide finer cuts of the diagnostic groups using the same grouper that Zeno used on the emergency department. We'll also provide more on member characteristics, so you can get a better cut at some of your target groups with respect to age, race, ethnicity. And we can also go at finer level of detail with respect to geography, going to county level as opposed just to the ACH level for members. And that product should be out toward the end of October.
And Krista?
Hi, so I'm not giving an update on a data product, but a few calls ago it was mentioned that we could have a request for an in-person meeting for all of the ACH data leads with the AIM team, and we are working to coordinate that. So you should all be receiving a survey from Stella, our wonderful admin, soon with some dates. Then you can vote on that. So they're all dates in October. And to try to be most convenient to everyone, we will actually be meeting at DOH in Kent. So hopefully a little closer for anyone who may be flying in. So if you have any ideas on what you want to cover in that meeting, again, this is Krista Concannon. You can email me or email the AIM email address, and it'll get to me. And we'll also set up a separate call for anyone who wants to participate to talk about what we want on that agenda. We're thinking 9 a.m. to 3 p.m., so just about a full day in Kent sometime in October. And on maybe today or possibly tomorrow, you should be receiving that survey of what dates work well for you. And then we can plan or schedule a planning meeting. And really, it's for the ACH data leads. It'll be great to meet everybody in person, and whatever topics you want to cover, we can arrange to put that on the agenda.
Great, thanks, Krista. It looks like we have a question. Let's see.
I think if they can't respond.
This is, I think, a question around creating the keys. So maybe this will transition nicely into Karen's session, and we might want to, the question's a little complicated on the keys, so maybe Nick could reach out directly to the ACHs on that.
Okay, so this is Karen Jensen reading a question about clarification about what's expected with regards to the email from LAFA about creating the key and the public key. So we'll get you some more information. So if you could, you know, send your specific question. I'm not sure which ACH this is coming from, but likely it's coming, several of you have similar questions, and we'll get you some answers. And that is a nice segue, because thank you all. We do, in order to transmit the sensitive data products, need to transmit via a secure file transfer protocol that does require a one-time establishment of a relationship, and via this key system, you don't need a new key every time we share data, but you have to get set up the first time. And we do have some other projects where we have used this system, and once it gets going, and we have this system worked out of where to deliver data and how you to pick it up, then it should go pretty smoothly. So we'll follow up with you on some more information there. And so thanks to all who have responded to the questions about, responded with the information about who's going to be responsible at your end about receiving the data, so we can be working one-on-one with folks. And also, we've had some questions come in particular the last couple of days, but even before then, that I have referred to Angela Hansen, who's the contracts professional that I've been working very closely with. So if your ACH isn't going to receive the data directly, but you're going to have, you want it to be sent to a subcontractor of yours, those are some issues that we'll be working through with Angela. So we're really, I want to segue a little bit to the data product summary we sent out with last week's weekly message, because that's going to tie together to the idea of when and how we'll be able to transmit the sensitive data products, because we want to build some granularity into that and really estimated production schedule, so that we can have some predictability for some expectations for ourselves and predictability for you for when we think that the sensitive data set will be all the way through our process and ready to transmit. We are aiming for kind of a batch production, and Fridays being the day that we would be providing the sensitive data products out. So using kind of more of a batch process, and working through, how is it that we want to work with you to make sure you're interested in these data products. We don't want to be just simply putting a sensitive data product out there or on a shared folder for you to pick up if you don't want it. So we'll be working that through in the next couple of weeks, and more information to come on that. But as always, send us your questions HWAIM, that's our Healthier Washington Aid mailbox that we stepped up about a month or so ago, and it's monitored daily. You also have the list of your AIM team data contacts, or you can email or call Kirsten or myself. Again, I've said this before, we truly aim for no wrong door. And so if you get a hold of someone who's not the subject matter expert for your question, we will get you to the right person.
Okay, we have another question. Thank you very much, Karen. Was that the end of yours? I don't want to interrupt you. There was a question about when Zaino's data product will be available, and Zaino has back at her desk already working, so although here she comes.
I'm listening in.
She's listening in. Let me say that at this point, it's not so much a constraint on her end. I think she's produced the data and is working right now to produce it for all the ACHs, and we'll have that done. It's more of our internal process. So I think the hope is very much that we are getting the last review and acceptance at the healthcare authority, and that we'll get Better Health Together, or Greater Columbia. Greater Columbia out the first pass of this very soon. We got the okay to send it out before Friday, so that's our expectation. Then we're meeting with all of the internal actors to say, okay, let's look at the process that we went through, and let's see how we can streamline it and make it faster and more efficient. And as we're doing that, we're going to be getting Zaino's additional products out. So without promising too much, I'd say that I really expect that to not be a long process, and by the end of next week, I think the next Friday, you'd have those data products.
Not this Friday.
Not this Friday.
I promised myself to be done with my part by this Friday.
Yeah, I think at this point, it's not a matter of the analysts really taking the time. It's more getting our internal data governance processes to handle really this new and exciting kind of product for us. And I think once you start to see these analytic-ready data sets, you'll really see what great potential they have. And there was an add-on to that question, Zaino, so don't leave.
Okay.
Did you mention using CCS categories? What are the groupers?
CCS.
She confirms CCS is a category.
Yes. And who is the person asking the question?
Ali?
Yeah, it's not one.
Okay. Yes. Because these, I think, this particular grouper is more, I think, better suited for ED data, because it includes both chronic and acute conditions, and we found out that the ED use is mostly, by acute conditions, and I think you guys will like this grouper.
Excellent. Thank you, Zaino. The next question is the joint ACH data meeting that was mentioned going to be coordinated with the October 23rd technical assistance meeting that also includes data? And it was our intent for this to be a separate meeting where we would discuss other issues that were identified between ourselves and the accountable communities of health. I think one of the big topics that came up on developmental council call, and certainly we've been thinking about a lot, is measure attribution to providers and how that might be handled. So that might be one of the discussion items during the in-person session that we were planning with ACHs. So let us know by all means if it would be more convenient for you for us to schedule these sessions close to each other, or to space them out more, because we can certainly take that into account. We realize there are a lot of things going on right now, and we certainly don't want to create an additional burden. We just think it would be a great opportunity to get everyone together. We also know and support that the ACHs data leads might want to convene on their own without the AIM team, and we fully support that. But we would assume that you would you would organize that among yourselves. So, any other questions, Missy? No. All right, I just have a few other items. One is that we realized that this move towards analytic-ready data products is not necessarily going to meet every ACH need, and there's certainly going to be some needs for increased visualization. So at the same time that we're working to create analytic-ready data sets, we're also working on some dashboard visualizations in Tableau, and we're working through our internal processes to make those visualizations available to ACHs. And I think we're in somewhat of the same state that our ability to produce dashboards seems to be outstripping healthcare authorities' ability to move through the governance process and create a governance process that supports that. So we're working very much on the review process right now, but we should be able to get out some, I think, really useful and creative visualization products for you. And if you're interested in getting more visualization products, we'll have avenues to get that kind of interaction as well, so that we can really make products that are tailored to your needs. Since we're kind of at a point where we don't have a lot of Category 1 or sort of the suppressed summary level data product requests, we're going back and looking through the existing requests that have come to us and trying to identify opportunities where we might have missed a piece, we've responded partially, or maybe we've responded with a product that we have now that we could put together, but the request is really beyond that, and it might provide an opportunity for us to develop a new approach or maybe expand our existing approach. So we are going through all of the previous data requests, but it would help if you have a data request that you still feel is hanging out there, to send that request through, again, through the Healthier Washington AIM email, just to alert us in case we miss it. As I said, we are going to try to go through and identify opportunities. One of those, for example, we have a call scheduled this afternoon with Nicole and Stacy, I believe, and David Mancuso to talk about the high utilizer emergency department use. So we are, as I said, trying to run those down, but if you feel like something is hanging out there and you're waiting for a response, please let us know. A final point is the Healthier Washington Data Dashboard has its new release scheduled for, I believe, October 20th. Mm-hmm. And John Bauer here has been working with Providence Corps to code and validate the inpatient hospitalization measure. And so that will be included in this release. All the measures will be updated with the latest HENA specifications and with calendar year 2016 data. So we're excited about that. Krista has a project she's working on to get out what we've called tabular data, a tabular report on the data underlying that dashboard. And we're also looking at the development of one of these analytic-ready data sets on that data. So that would be really exciting if we're able to bring about all of that in October. And looking at that, then I think you'll have an update for the sort of historical toolkit proxy measures for all the measures that are currently in the Healthier Washington Data Dashboard. RDA will be able to update most of its measures. There are some reproductive health measures that are produced from sort of a different part of RDA, relying on different data sources, and those won't be updated until December. And there are also other measures that are still under development. And as soon as those measures are coded and validated, they will be released out to the accountable communities of health so that you do have historical data. 3 or 2 that Krista's working on are chlamydia screening and well-child visits to 15 months. I believe Shalini is working on statin therapy. And then Dan Bolton on our team is working on the opioid measures that the 3 collaborative developed the specifications for, so those just came out recently. And an area where the Healthcare Authority hasn't reported in the past is on oral health measures. And Sheila and Stephen are working with internal stakeholders to develop the data sources to code those measures. So those might take us a little longer, but we are in the thick of the process of finalizing the specifications and producing those measures. And Dan has just joined us. Did you want to add something, Dan?
No, yeah. If there are any questions, I'm here.
Okay, well, I don't know that they'll come in if they are. We're also in the final parts of contracting to expand the Healthier Washington Data Dashboard for official toolkit measure tracking. And that will include the official baseline data. And we expect that that contract will be done soon. We'll be able to get down to work. ACH data leads will certainly be involved in that work, determining what kinds of subdivisions and breakdowns will be useful for the toolkit measures. And the target date for that to be available would be October 2018. So that is all, those are all the updates I have. And we have a couple minutes here, so we'll just wait a minute or so and see if there are any questions. And then if they're not, we'll close up the call early. So a question came through. They understood that chlamydia screening and well child visits 15 months might be available in October, and that's certainly what we're working for, but that all the other reproductive health measures would not be available until December. These are RDA-produced measures, and that is our understanding, but I think just to make sure, we will go back and confirm that those are right now on an annual cycle. The hope is that when the measures are reported in the Healthier Washington Data Dashboard, so starting in the fall of 2018, next fall, they would be updated on the same schedule as the other measures in the Healthier Washington Data Dashboard, which is quarterly. And so the RDA team is working towards that functionality. But right now, they're just working it into their sort of regular production schedule, which is annual. So that's our understanding, but we will get confirmation of that to ensure that all the reproductive health measures are on that same schedule. So what Missy has suggested, our assistants here with this webinar, is that we can go ahead and hang up, but the webinar will stay open until 3:30. And so if you have additional questions, you can send those in and we'll get you the answers to those questions. If any of our answers weren't clear or you'd like some additional clarification, I know that it's not always the most convenient to type these in. By all means, give us a call or send it in by email and we can work to get you the answers that you're looking for. So with that, thanks for attending and goodbye.